Thank you. I'm sure you share the opinions of those who've commented to me that they found the morning to be enrich their understanding of these questions. It certainly has mine. And we'll look for more enlightenment this afternoon from a broad range of speakers talking about countries around the world in which efforts toward universal coverage have been initiated. At the moment, I just want to introduce the introducer, the chair of the session. Tessa Torres is the chief at WHO. I'm not sure your current title, but let me see if I can get close to it. Tessa has been the chief of the WHO Cost Effectiveness Analysis Unit that has developed a library and methodology for cost effectiveness analysis. It's been an extremely valuable resource around the world to low-income countries as well as others. And many years ago, Tessa, who has a very broad range of interests, took a special interest in ethics and has been a kind of educator and den mother, as we say here, to most of us on the faculty who have been working with WHO on various projects. So it's with joy that I introduce Tessa to the group and ask her to chair the session.
Thank you, Dan. I don't know what a den mother does, but I do have 5 children, so maybe that would qualify me for being a den mother. What I do know, what I do with these philosophers here, with whom we're working with, is I always tell them, stick to the reality. Don't give me your case studies or your choices or whatever. I mean, just don't give me your theoretical choices. Just please tell me what we can tell the policymakers in the country and make it a little bit clearer for them. And I don't know if that's what the den mother does, but that's what I see my role being in this group. But anyway, let's go to the country experiences. We have a very, the previous discussion showed you the 3 axes. You talk about populations covered, you talk about the financial protection provided, and you talk about the services which are being provided towards the goal of universal health coverage. Now, as we found out, this is really quite a broad range of choices, and even within this, you will have many of the implementation issues or the paths that are chosen, which also have implementation issues. So we, after talking about this at the global or at a very normative level, maybe at the start, we are now going to look at the specific country experiences. And I have to warn you, you really have to listen carefully because there is a huge variety in terms of the topics that will be touched upon in this set of country experiences. And it will be a real challenge in the panel to get this going once we actually start getting the questions. So you need to write down your questions after each speaker because they will be tackling different topics. And I'm not sure, we'll try to keep on time so that we have enough time for the questions. So we'll start with the first presentation, which is on Rwanda. It is going to be done by Dr. Lisa Hirschhorn, and she is an assistant clinical professor of medicine at the Harvard Medical School, associate physician at the Division of Global Health Equity, and visiting scientist at the Harvard School of Public Health. So she also serves as the director for monitoring and evaluation and quality at Partners in Health. She has worked in HIV for the past 25 years, and she has worked specifically in Rwanda for about 4 years now, and this is what she will be discussing. Lisa?
So thank you for the introduction and good afternoon. So what I was asked to do was to talk about Rwanda and universal coverage, and I obviously want to start with a caveat, which is that I'm not actually talking for the country, although I did talk to the Honorable Minister and got some of her slides, as you'll see, to help keep me somewhat on track. But I'm going to talk a little bit about some of the things that I'm very interested in, which is this sort of tension about quality and equity. And I come at this both from the perspective of somebody involved in monitoring and evaluation, but also as a clinician. And some of the tension that you'll sort of see in this is some of the tension that's facing people as they're making some of these decisions. So there's been a lot of discussion, and I sort of hesitate to say anything about universal coverage to this particular group, but the focus is, again, this ensuring access and the financial risk protection. But as we sort of think about this, and I'm going to talk about this really within the context of a large project that we have ongoing in two of the districts in the eastern province of Rwanda, in southern Kayanza, and Kirehe, in very close partnership with the Ministry of Health, that we are really focused on this idea of access for all, but also on quality, and finally on a responsive system that meets the needs of the community. And I know that they sort of fit into some of those, the dimensions, but really putting in them explicitly. So one of the ways that we think about it, and this is particularly at Partners in Health, is traditionally when we look at quality, there's sort of three domains: systems, activities, and results. And then we also have a fourth one that we focus very much on, which is sort of customer-defined quality, health system responsiveness, satisfaction. But the one that I really want to focus on is what we call the fifth area of quality, which is equity. And when we go about and sort of make some of the decisions that we have to make in the setting of limited resources, really trying to figure out how to balance all of these. So Rwanda, I'm sure a lot of people are very familiar, but just it's a country of about 10.6 million people. Just to give you some sense, compared to Massachusetts, about the same geographic size. Massachusetts has 6.6 million people. Life expectancy is 56 years, up from 28 years in 1994, and has really been, I think, very much held out for the remarkable progress that it has made. And the per capita health spending is about $55 in 2010. So what Rwanda did was they implemented a system of mutuelle de santé, mutuelles, which was to ensure that the underserved populations have an effective means of improving access to care. It's a community-based health insurance program that's been established by the government of Rwanda, and it's really one of the critical components of the national health strategy to provide universal health care. In 2000, it was piloted. In 2006, it was fully implemented. And then in 2008, it went through some further regulations and strengthening. And there was actually some work that was then done to actually say, well, was it effective? What was the impact? And what was done was looking at child and maternal care coverage between 2000, so at the time when it was first piloted, to 2008, as well as household catastrophic health payments and enrollees' medical care utilization. And the bottom line was that it was very positive. If we look at this as the increase in mutuelle coverage from the pilot phase up to 85% in 2008, and we see associated with that increase in child care coverage, increase in skilled birth attendant. So we definitely saw some increase in medical care utilization, and also that it appeared to protect households from some components of catastrophic health spending. You could see the decrease from 2000 to 2006, and if we look at the uninsured versus the insured, we definitely are seeing some protection. So it was definitely achieving the goals of the government. And this is further data. This is from a paper that was recently published by Paul Farmer along with the Honorable Minister Dr. Binwahu, which also showed, again, this really dramatic increase in uptake of a variety of different health interventions. And this is, again, focusing on maternal and child health. But what about equity? So did this actually help everybody in the same amount? And what we saw was that while it helped everybody, there was still some areas where there clearly was inequity in the benefits. And this is that we saw a significantly lower rate of utilization, and this graph actually shows that there was a higher rate of catastrophic health spending if you're looking at the poorest. So again, yellow is uninsured, green is people with the mutuelle. It gave protection regardless of where you were. But if you look at it, there was still more catastrophic spending among the poorest. So there clearly was a huge amount of success, but clearly some areas in terms of how to make sure that it was equitable in terms of the coverage. Despite that, what you can see, and this is looking at decline in child mortality, that we've been seeing a really dramatic and very impressive decrease both in the rural areas and in urban areas. And among the poorest, again, we are seeing a drop in mortality. So again, it is effective across all of them, but not as effective as we might like. So to just very quickly sum it up, the experience suggests that this type of community-based health insurance schemes can be very effective, even in very poor settings. But the challenge really is to ensure that access and protection is really equal for the poorest. And there's some schemes that are using now financial assistance for the lowest poor. But when you're sort of looking at it more from a little bit more from a clinical perspective, the challenge is, so here you have the overview of the healthcare system, which relies a lot on community health workers. But the challenge is this, that the Rwanda healthcare worker density is only 0.84 per 1,000. And so while you might be actually giving coverage to people, you have to make sure there's somebody there to actually provide the care when they're actually showing up, at, regardless of whatever level of the health system that they're accessing. So what do we want to do about that? So let's say we're going to do some task shifting. If the quality is similar, what do we want to know about the scope? And this is actually a choice that we had to make, which is, do you take a few health centers, and there's 23 or so health centers in the 2 districts in which we're focused on for the FIT grant. Do you staff a few of them with higher level nurses and an MD who's able to provide more advanced care, whether it's non-communicable diseases, HIV, or other ones? Or do you ensure full district coverage for more basic care, first-line antiretroviral therapy, basic screening and treatment for NCDs? And this is really the tension, I think, about when we talk about universal coverage and people talk about for what and how deep. And so what are the possible responses? So Rwanda actually has done 2, one of which is to increase the training, and there's an enormous initiative called the HRH initiative, which is to train physicians, nurses, healthcare managers over the course of 7 years and increase the ability to actually train more people within the country. But what I'm going to focus on is task sharing, just very, very briefly. So for people who don't know, task sharing is, to quote WHO, the rational redistribution of tasks among health workforce teams. And the specific tasks are moved when appropriate, and I highlight that, from qualified health workers to health workers with shorter training and fewer qualifications. And the view is this isn't just a short-term fix, but really a very strategic approach to strengthen the health system. So the question is that I'm going to sort of put out there, and hopefully we can then discuss in the, during the discussion period, is can task shifting expand universal access while it ensures, sustains, or even improves quality? And just going to end with a little bit of sort of information which suggests that the answer is probably yes, but we're still not totally sure. So a number of studies have shown increased access and uptake, and most of this started with HIV, but then has moved on to other areas. But again, we have to always ask ourselves, what if the quality is not as good and the care is not as effective, but we're still reaching more people? And again, this idea of, is it right to provide basic care access, but with providers not able to provide more advanced care or to ensure access at another site? So if we can provide first-line antiretroviral therapy for people with HIV, but if they start to fail that treatment and we can't give them second-line treatment because you need a doctor to do that, is it better to actually have full access to first-line, or should we actually be focusing on second-line? And the data, again, in terms of quality in HIV is actually very good. If anything, sometimes nurses do better. Here in the U.S., nurse practitioners actually do better than general internists in terms of outcomes. And there's been other data from, for example, surgical task sharing that has shown equal results. So from the perspective of me as a clinician, I want to provide the best standard of care that we possibly can. Public health ethics require the health system to consider how to help patients who cannot access care. And so how do we actually bring into universal coverage the focus of quality of care for few with access to a surgeon versus, for example, the silent majority who do not? So to quote UMS, islands of excellence in a sea of under-provision. And so, and a quote from Dr. Benoit, that continued policy and action amounts to unwarranted healthcare rationing and as such is ethically untenable. And so I think that that in conclusion, that public insurance is a key tool to ensuring increased access, but that as we do this, we can't sort of just pat ourselves on the back, but the focus has to remain on ensuring both equity and quality. And to do that, we have to measure what we're doing and make sure we're doing it well. That task shifting is a potentially very valuable tool when done well, and that can sustain or improve the quality and increase access. But we really need to do more work to determine the most effective use and the limits of task shifting and other innovative and potentially scalable approaches so that we are ensuring quality, we're giving as much and as deep care as we possibly can with limited resources to the most that we are able to reach. Thank you.